Namaskar. On behalf of AYUSH Samriddhi International Webinar Series, we would like to welcome you all at milestone of 2867. Thank you very much for supporting us to continue this journey up to infinite. We are very glad to have Dr. Rajuta N. Trivedi, Dr. Rajuta Narendra Bhai Trivedi, renowned Ayurvedic gynecologist, ex-associate professor and HOD, JP Government Ayurvedic College, Bhavnagar. She is residing at present in Hyderabad, so we will like to welcome Madam from Hyderabad. And today's topic is very unique and common. At present, due to our Pragyaparad, due to various radiations and unsuitable atmosphere, environment, and AQI, everything is the cause of our endocrinal disturbance. So thyroid disorders in female and its impact on fertility, and whether this impact is so serious to cure by Ayurvedic management. So I heartily welcome Dr. Rijita Joshi ji, and I would like to request our Vice President IRES of West, Dr. Nishan Shukla ji, Jamnagar, to welcome her. And I would like to welcome Vice President Central, Dr. CP Sharma sir. Welcome all the experts, and welcome above all YouTube viewers. For them, we are creating this video. Dr. Nishan Shukla ji. Am I audible to you, Dr. Nishan Shukla ji? I hope his connection is disturbed. So I take this opportunity to invite Dr. Rajuta ji. Welcome, Dr. Rajuta ji. Welcome.
Okay. Thank you very much, sir, for inviting me for this webinar. I am very grateful for this. I'm not taking much of a time and just start my presentation. So please allow me to share my screen.
You are allowed, madam. You are allowed.
हरिओम नमस्कार.
हाँ, जब तक मैडम नमस्कार. आपके हाथ से स्वागत चाहते थे रजिता जी का.
यस 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 बीच में कनेक्शन जो है वो छूट गया.
रजिता जी शेयर कर रही हैं तब तक. प्लीज शेयर रजिता जी. हाँ, निशांत जी. निशांत जी कहाँ गए?
आज के इस इम्पोर्टेंट वेबिनार थायराइड डिसऑर्डर्स एंड इनफर्टिलिटी पर हम आज चर्चा करने वाले हैं. थायराइड डिसऑर्डर इनफर्टिलिटी का सबसे बड़ा कोज है और ये पीसीओएस के साथ भी रिलेटेड है, ये हार्मोनल इश्यूज के साथ भी रिलेटेड है, ये जेनेटिक डिफॉर्मिटी को भी एंड अप कर सकता है. तो ये इसके काफी सारे जो है वो पहलू हैं और इन्हीं चीजों को आज हम अपने एक विद्वान वैद्य श्री रुचिता जी से हम इसको ज्ञान प्राप्त करेंगे. ओवर टू पवन शर्मा जी एंड वेलकमिंग रुचिता त्रिवेदी जी.
यह संयोग है कि आप दोनों क्लासमेट हैं और यहाँ मिलाने के लिए हमारा ये मंच आप लोगों के साथ है.
हाँ, रुचिता जी मुझसे हम दोनों एक ही बैच में थे. सर मुझे फोन आ रहा है, मैं थोड़ा उसको निपटा लूं.
जी 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 रजिता जी, प्लीज
Okay,
शेयर.
sir. Sir, my screen is visible, right?
Yeah, you are visible, not your screen.
Okay. 1 second, sir.
No problem. Please take your own time.
Okay. Am I?
नहीं, अभी तक तो नहीं आई मैडम।
1 second. जब आ जाए तो बताइएगा।
हम्म। पहले शेयर फिर शेयर स्क्रीन।
हाँ, ऐसे ही किया है।
हाँ, अब आ रही है, आ गई, आपकी स्क्रीन आ गई। आपकी स्क्रीन दिख रही है, आप म्यूट हैं। आप प्रेजेंटेशन खोल लीजिए और म्यूट खोल लीजिए, आपकी स्क्रीन दिख रही है। ओपन द प्रेजेंटेशन। केवल पीपीटी ऑन करना है मैडम, आपकी स्क्रीन दिख रही है। पीपीटी ओपन कर दीजिए, पीपीटी आ जाएगा स्क्रीन पे। निशांत जी, डॉक्टर निशांत शुक्ला जी।
Stop sharing. Okay. Now I am sharing my screen.
पीपीटी को पहले खोल के रख लीजिए स्क्रीन पे।
हाँ हाँ, रख लिया है सर, रख लिया है। 1 second. हो गया आप?
नहीं मैडम।
आवाज नहीं आ रही अभी भी?
नहीं नहीं,
और स्क्रीन?
आप दिख रहे हो, स्क्रीन नहीं दिख रही है। आप मुझे व्हाट्सएप कर सकते हैं।
1 मिनट, 1 मिनट। हाँ, मैं व्हाट्सएप कर सकती हूँ आपको।
हाँ,
मैं
व्हाट्सएप कर दीजिए, मैं दिखा दूंगा।
हाँ, 1 second. व्हाट्सएप कर दिया है। हैव यू फाइंड आउट?
अभी तक तो नहीं आया मैडम।
1 second. लिंक भी शेयर कर दिया है।
कहाँ शेयर किए हैं?
आपको व्हाट्सएप नंबर पे सर।
नहीं तो,
1 मिनट,
मैं व्हाट्सएप खुला हुआ है।
1 second.
इसमें चैट बॉक्स में डाल सकते हैं कि कॉपी पेस्ट?
हाँ, वो भी कर सकती हूँ और ये भी
हाँ।
कर रही हूँ वापस से।
यहाँ आया नहीं अभी तक।
हाँ हाँ, 1 मिनट, 1 मिनट। हाँ, शेयर कर रही हूँ चैट बॉक्स में भी।
चैट बॉक्स से भी मैं दिखा सकता हूँ। हम्म, अभी तक आया नहीं वो क्यों?
ठीक है,
कॉपी
आया,
पेस्ट
कॉपी
चैट
पेस्ट
बॉक्स में।
किया।
हम्म,
चेक बॉक्स में कॉपी पेस्ट किया।
कहाँ किया?
उसमें भी नहीं जा रहा है।
हम्म,
1 सेकेंड, मुझे एक बार लास्ट टाइम ट्राई करने दीजिए, वो मैंने ओपन करके रखा हुआ है। देखिए स्क्रीन।
नहीं तो मैडम।
1 सेकेंड। अरे, मुझे आप स्क्रीन शेयरिंग के लिए अलाउ किए हैं सर?
हाँ जी, हाँ जी।
क्योंकि
बीच
मेरा
में
यहाँ शेयर बटन ही ओपन नहीं हो रहा है।
ये देखिए, मैंने तो जब आपका पहली बार तो आ गई स्क्रीन, तो आ गई, आपकी आ गई।
और वॉइस,
हाँ, आ गई,
वॉइस
पीपीटी आ गया।
आ गया ना?
आ गया, आ गया,
ओके।
आ गया, आ गया। आप स्लाइड शो में यस, ग्रेट, ग्रेट मैडम।
ओके। ओके, so I am audible and I am visible, my screen
यस,
is
यस,
visible.
यस, यस, यस।
Okay, so shall we start right now? So thyroid disorders in women, impact on fertility and Ayurvedic management. Sorry for a little bit inconvenience. Let's start the topic first. What is first of all, why this topic is important? So right now, thyroid disorders in female are often underdiagnosed, and early symptoms are overlapped with conti- with routine lifestyle complaints and all. So thyroid dysfunctions are very important to know, to diagnose, and there are a rising incidence of thyroid dysfunctions in present scenario. And particularly, we are taking this topic for a fertility point of view. So, early identification and fertility outcomes are also important. Uh, so, uh, so uh, this topic is important because it is having a very uh, functionable thing for fertility, right? First of all, we should know what is a thyroid gland anatomy. We all know. So, it's a butterfly shape gland in a lower neck, and its vascularity is very much high, particularly. Which supports continuous hormone production. Uh, what is the physiology? HPT axis. Hypothalamus, which releases the TRH, and which effect on the pituitary, which releases TSH. Thyroid gland mainly produces T3 and T4. They have target tissues and metabolism. TRS and TSH through a negative feedback, they supports elevated level of T3, and T4 suppresses TRS and TSH through negative feedback. So this feedback makes TSH more sensitive marker for a thyroid dysfunction. So here we have three thyroid hormones, particularly T3, T4, and calcitonin. It is from a parafollicular C cell. Right, so 80% of circulating thyroid hormones is T4, and peripheral conversion to T3 ensures metabolic regulation across all body organs. So thyroid hormone synthesis. So basically, thyroid hormone synthesis is a stepwise process which is regulated by TSH. Iodine tapping is the rate limiting step. TPO drives oxidation, organification, and coupling. Therefore, anti-TPO antibodies in Hashimoto's thyroid directly impair hormone synthesis. So, although the gland mainly produces T4, and body tissues convert T4 to active T3, which regulates metabolism. This pathway helps understanding drug targets and iodine related disorder. And mono MIT means a monoiodotyrosine, or a DIT means diiodotyrosine, right? So, what is the role of a thyroid hormone in metabolism? So basically, we all know that thyroid hormone raises the basal metabolic rate by increasing mitochondrial activity and oxygen consumption. And they enhance carbohydrate metabolism uh, uh, by increases glucose absorption and stimulating a gluconeogenesis, right, or a glycogenolysis in lipid metabolism. They promote fat breakdown and increase LDL receptor activity, which lowers cholesterol. And hence hypothyroidism often shows high HDL level. So thyroid hormone does not only affect on fertility issues, or estradiol, or prolactin levels, or progesterone level, but it also has an effect on LDL levels also. So hypothyroidism often shows high LDL level, while protein metabolism is also depends on the hormone level. So normal thyroid level supports protein synthesis, whereas excess TSH hormone causes protein breakdown and muscle wasting. So there may be a cardiovascular effects, which include increased heart rate, contradictile, and cardiac output due to heightened beta androgenic sensitivity. So overall, thyroid hormone regulate temperature, body weight, and energy expenditure. Effects of a thyroid hormone on other body system apart from fertility issue. So first of all, as we know, in heart they increase rate, and they while lower levels, so slow pulse, and reduces cardiac output. In the nervous system, if we see the deficiency of a thyroid hormone causes slow thinking, low mood, while excessive thyroid means hyperthyroidism causes anxiety and irritability. They also regulate gut movement in a GI system. So, hypothyroidism, as we all know, causes constipation, and hyperthyroidism increases the motility, which leads to loose motion. So, musculoskeletal system. So, in a musculoskeletal system, uh, uh, bones are affected through the changes in protein turnover, which is affected by a thyroid hormone, and bone resorption is also affected by a lower level of thyroid hormone. Skin and hair changes are also reflex, because it regulates the texture and hydration. So hypothyroidism shows dry hair and skin hair fall and dry skin, while hyperthyroidism shows moist skin. Thyroid hormones also acts nearly every body cell, right? Not only HPO axis. They have a profound effect on estrogen, androgen, fertility, and menstrual function. Thyroid hormones may cause delayed onset of puberty and ovulation, infertility, or recurrent pregnancy loss. If we see the what is a effect of thyroid on the HPO axis, how does it influence the HPO axis? If we start from the hypothalamic level, T3 influences the pulsatile release of GnRH, which is essential for a normal LH and FSH secretion from a pituitary. Adequate ovarian follicular development and ovulation is also depend on this rhythm. So thyroid function disrupt this balance. If T3 is reduced, T3 further slows GnRS pulses, while excessive thyroid hormone can overstimulate them GnRH pulses. So in both extremities, they lead to alter ovarian steroid production and impaired luteal phase functioning. This explains why even mild thyroid abnormalities can cause menstrual abnormalities or irregularities or infertility or maybe a subfertility. So hypothyroidism slows down the GnRH pulsatility, which result in reduced amount of LH and FSH, which creates an ovulation or a delayed ovulation or irregular ovulation. It may create a luteal phase deficiency also. Sometimes stress cause the increased prolactin level, which is also suppresses ovulation. And hypothyroidism is also responsible for an increased prolactin level, which is further leads to an ovulation or irregular ovulation. Hypothyroidism may cause oligomenorrhea or menorrhagia, and infertility risk is increased. Now goes to hyperthyroidism. So hyperthyroidism increases the sex hormone binding globulin SHBG, which reducing free biological active estrogen and progesterone, means estradiol particularly. These these are altered hormonal availability and disturbed ovarian feedback to the pituitary, and the follicular phase may shorten. Although some female continue to ovulate, but the quality of ovum and the consistency of ovulation often decreased, which leads to subfertility or infertility. In more severe hypothyroidism, when T4 is increases above 5 or a 4 NU, anovulation can occur due to disturbed GnRH and FSH-LH patterns. So menstrual cycle may become frequent or very light. If a conception occurred during untreated hypothyroidism, there is a higher risk of a miscarriage, preterm birth, and maternal complications also. This all this scenario highlighting the need of a strict thyroid control. Major thyroid hormone disorders. This slide summarize this thing. So, all we know that hypothyroidism means T3 and T4 level are decreased and TSH is increased. Symptoms and causes are also self-explanatory in the slide. While in sorry. While in hyperthyroidism also there is a T3 and T4 is increased, and TSH is decreased. Hashimoto is the most common autoimmune cause for hypothyroidism, while Graves' disease is most common cause of hyperthyroidism. Here we so okay, what is the subclinical forms of abnormal TSH with normal T3 and T4 are especially important for females who are planning for a pregnancy or who is infertile. Understanding the pattern of TSH and T3, T4 helps us to diagnose and differentiate the each condition accurately. Subclinical hypothyroidism may progress to overt hypothyroidism, and especially with the positive anti-TPO antibodies. And positive anti-TPO is also positive in Hashimoto thyroid disease. In addition, TSH is raised and low or a normal T4 for Hashimoto Graves disease. So we should also know about all this condition. So here is some facts which ATA means the American Thyroid Association published in 2017. The guidelines state that every female undergoing infertility evaluation should have a TSH test performed. Thyroid dysfunction can affect ovulation, luteal phase stability, and implantation. So, identifying abnormalities early is essential. Overt hypothyroidism must be treated before conception because it significantly reduces fertility and increases miscarriage risk. Why it is also important to treat subclinical hypothyroidism. Even subclinical hypothyroidism affects fertility even when free T4 means if T4 is normal. Because T4 is very much normal and TSH is slightly elevated, if it is rises about 2.5, then also there are higher chances of miscarriage, or nowadays due to any male infertility, patient opts for IVF or ICSI. So free if TSH is above 2.5, so it also lower down the success rate of IVF or ICSI. It also disturbed ovulation, and anti-TPO, if it is very positive, then it worsens the fertility outcome. Here, according to allopathic science, levothyroxine treatment improves the result. Now, if we saw the ATA and AACE, American Association of Clinical Endocrinologists, they also recommend L-thyroxine to lower down the subclinical hypothyroidism when if even a pregnant female tries for a natural conception. If we consider a thyroid or antibodies and sub-fertility, so thyroid autoantibodies can negatively influence fertility even when thyroid biomarkers like TSH and T4 appears normal. Research consistently show that the anti-TPO and anti-TG positivity increase miscarriage risk and reduces implantation of a fertile ovum. It also decreases the live birth rate. Here, if a female is clinically subfertile, then also we should check out the anti-TPO and anti-TG antibodies. Now we say that AACE guidance is also suggests that if TSH and T4 is normal, female is subfertile. So at that time, we should consider anti-TPO testing, where TSH is repeatedly slightly high from 2.5, or a patient is having a recurrent miscarriage, or if there is underlying thyroid autoimmunity also. Even patient is having had previously, some patient came with previously we have a thyroid disorder, and now thyroid is only 2.5 or slightly above that, so we stop taking medicine. So particularly this kind of subfertile female, we should try out again anti-TPO testing. So now our main focus is why hyperthyroidism is important in infertility. So all we know that research shows that untreated hypothyroidism is always reduces fertility. It disturb ovarian steroid balance and implantation, and miscarriage rates are very high if a patient is having recurrent pregnancy loss, RPL. In this case, untreated hyperthyroidism is maybe the cause behind this thing. Treatment definitely improves reproductive outcomes, and better conception rate are there when there is a control thyroid function. In mild or subclinical cases also, treatment should be based on TSH level or a TRAB level, or what are the fertility goals you have, age of patient, and his male partner's condition should be considered as well. So now our topic, Ayurveda and thyroid. So here the foundational understanding that in Ayurvedic Samhitas do not identify the thyroid gland as a separate anatomical structure. So condition like a hypothyroidism or a hyperthyroidism do not appear directly in classical uh, samhitas. Such condition always falls under the anukta vyati, means this is that not explicitly named but understood through dosha, dushya, agni, strotas, all principles. So, if we consider closest structure description are Galgand or Gandmala, they're referring to Next Valley. So, which are functional correlation is that uh, for thyroid disorder. So, thyroid hormones are regulate metabolism, much like Agni governs the transformation at tissue level and the systemic level. So, in Ayurveda, approaches thyroid condition through functional correlation rather than literal organ mapping. This is what my thinking about thyroid disorder, particularly in infertility. So if we so there are no terms related to hyperthyroidism or hypothyroidism. They described Galgand and Gandmala, right? According to, if we have to consider the closest correlation to allopathic science, it is a goiter or a thyroid enlargement, which causes resulting from iodine deficiency or autoimmune thyroiditis. That is what it shows. So, if we have to interpret the hormonal imbalance of thyroid, we have to interpret through a symptom, through dosh, dushya, dhatvagni, and agni, particularly on dhatvagni principle. So, see, this is my simple understanding this that Ganmala and Galgan is not at all a thyroid gland, but the symptoms and treatment are clinically very, very, very much useful, right? In modern reviews, if we saw that interpretative correlation is used for a treatment planning rather than literal organ to organ mapping, right? So here for Ayurvedic practitioners also, they must confirm modern diagnostic level, means TSH, free T3, free T4, anti-TPO, and USG if needed, before designing any kind of Ayurvedic protocol for infertility. If we modern thyroid physiology describe that T3 and T4 as the regulators of BMR, so thermogenesis, menstrual regularities, cognition, energy. According to Ayurveda's metabolism, it is governed by Agni. Jataragni handles digestion, while Dhatvagni transforms each dhatu. So, when thyroid function is low, the comparison is Mandagni, is slow metabolism. when excessive it's Trikshagni means hypermetabolic rate. Multiple research also confirm that correlation, and in a clinical scenario also we correlate like this, and results are very encouraging regarding infertility. So here if we do Ayurvedic correlation of hypothyroidism, cough heaviness, and sluggishness also reflect the metabolic and hormonal slowdown, which is also seen in hypothyroidism. Vata disturbance is also self-explanatory by dryness of skin, hair fall, infertility, menstrual irregularity. So if we so the samprapti or a pathogenesis is like Jatharagni, Man Jatharagni causes Dhatwagni impairment. There may be there arm formation or deposition, there obstruction of Rasavah Strotas or a Medovah Strotas, Medovah Strotodustri, and symptoms are identical like weight gain, lethargy, coldness, edema, constipation. Hyperthyroidism again presents the classical pitta features like heat, irritability, sweating, and vata features like tremor, tachycardia, agitation. So excessive agni leads to tissue depletion, means dhatupa, which explaining weight loss and muscle wasting. And if we so the thyrotoxicosis or toxic goiter also, it functionally matches the pitta vata vishesha here and ati tikshna agni. Due to all these things, there is a heat tolerance, palpitation, anxiety, weight loss. Strotas. So mainly Rasvaha Strotas is uh, involved, which explains by a puffiness and weight gain, sluggishness, edema in hypothyroidism. Medova Strotas is also involved uh, by dyslipidemia or a weight disturbances, means weight gain or a weight loss in both cases. Manovaha Strotas is also included by it accounts for mood symptoms. There are mood swings, depression in hypothyroidism or anxiety in hyperthyroidism. So all these are considered central part of any kind of whether it is a hypothyroidism or a hyperthyroidism. Mainly these three strotas are involved. Particularly Rasvahastrotas is also responsible for infertility in female. Okay, if we consider autoimmune thyroiditis, means Hashimoto. There is no direct description regarding this disease, but we can consider as impaired immunity, means overchakshaya or Vata Kapha dominance is there, and Rasdhatu Pak depletion is also there. Basically, Vayu controls immune regulation, right? And Kapha governs structural integrity. When both are disturbed, autoimmune conditions may develop. And here also there is no organ mapping or this kind of thing we can do, but we can correlate this Hashimoto disease according to Ojukshaya Lakshana. So first of all, for infertility particular, lab value definitely help to define the severity of TSH. Anti-TPO means define autoimmunity. Morphology should be done by ultrasound if a patient is having goiter or Hashimoto, whatever. If we so Ayurvedic assessment, then we should know which dosh is involved, Agni, Strotodusti, and chronicity should be considered before starting uh, to treat infertility. So here is the this slide gives a stepwise integration protocol for Ayurvedic Vaidya. So first of all, start with the full modern baseline test and uh, parallelly Ayurvedic assessment also. For overt disease, prioritize evidence-based modern therapy and use Ayurvedic treatment and management. If a patient is having a subclinical or a mild abnormality, uh, then we can offer them Kashnar combination or Deepan Pachan or Panchkarma, and uh, s- monitor TSH baseline every 6 to 8 weeks. Okay, first here are the some of drug of choice regarding infertility, uh, particularly when thyroid disorder are there, patient is infertile or patient is subclinical fertile, then in our OPD we are using that this kind of drug means Drakshadi Kasai, Panchkol Churna, and very famous Gugulu Tikta Grut and Kashnar Gugulu, and sometime Kshirbala tail also helpful. So uh, in hyperthyroidism, pitta vat dosh involvement is there and tikshna. In this condition, we are using maha tikta grit shankvati pravalpisti. Kamdutha and pravalpisti both can be given. Mushtadi Quath and Patoladi Kashai also having fantastic results. Suchekhar Ras is also we are prescribing, particularly for a hypothyroidism, Snepan or Bashpasved, Virechan. Virechan we can do with the classical dravya. For a Snepan, we can use Panchtikta Krut or Indukant Krut. Anuvasan Basti or a Niru Basti also works fine. Here are also these kind of drugs are also does have a effect on infertility also. So the Shmul Kwath Nirubasti or Sahacharadi Tel Anuvasan Basti or Akshir Bala Tel Anuvasan Basti is also considered for thyroid disorder. Mm, in hyperthyroidism, Shidravya Virechan, Pitchaman Bastis, Takradhara or Amrudu Virechan is considered. So here in most our OPD, most of the cases, patient with infertility, we are using this kind of Kachnar Google Atik Degree, Punanavadi Kwat, and all these things. Kashnar, particularly if we talk about Kashnar Google, it is a classical drug for neck swelling or a gulgund, right? So it is a structural correlated for goiter. But if we consider pharmacological reasoning, Kashnar Google is having antifibrotic action, which improves thyroid tissue architecture, reduces lymphadenopathy. It also supports autoimmune swelling control. Mm. Likewise, Gugulutic the Grith is having a rasayan effect, and if there is a chronic stagnant TSH level, hypothyroidism level is there, then we are generally we are prescribing glutathione which is also having anti-inflammatory effect, and which improves cellular metabolism. Punarnavadi Kwath is also effective while there is inflammation or edema, particularly in hypothyroidic stage. Chitrakadi Vati. Particularly, Chitrakadi Vati is strong Agni Dipan, Chitrakadipan Pachan, as we all know. It reduces meth accumulation, and particularly in hypothyroid obesity, and it increases thermogenesis, enhances metabolic rate, if we consider it according to a modern pharmacology. And Chitrakadi is also having a ovulatory effect on an ovulation. So yes, in hypothyroidism, we definitely consider Chitrakadivati and Kanchnar Gugalu both. Guduchadi Quad again, it is immunomodulatory and rasayan drug, uh, which reduces CRP and infiltration, lymphatic infiltration in thyroid gland. And Guruchadi Quath is also described as Artav Janak in Bharat Bheshajya Ratnakar. So in hypomanoria, we are also prescribing Guruchadi Quath. Indukant Grut is a very ideal vodka for hypothyroid phenotype condition, and it nourishes dhatu. So if we go through the modern pharmaceutical science, it supports mitochondrial ATP production, and keep the base lipids also help T4 absorption, and also stabilize neuronal thyroid receptor sensitivity. So Indugrant growth is also considerable when hypothyroidism is there. Panchkol Churna is also Dipan Pachan and Ampachak, so we can also consider it. Here, Mahatik Grit again, it is a Pitsamak and Rasayan. We can simply giving Kamdutha and Praval Pasma, which is also reduces pitta-like hyperactivity, and doing cardiac excitability, reduces or stabilizing. Or Saraswat Churna is also having a good effect on insomnia if it is due to hyperthyroidism or due to increased pitta vata. It has a CNS claiming path effect on the CNS claiming pathways, which also reduces androgenic overactivity. Simply, if we do give a Shankhavati, which also works, hyperthyroid patient oftenly show Tikshna or hyperacidity. It also reduces, stabilizing the vagal thyroid reflex particularly, and it is very important for a hyperthyroidism. If we consider a panch karma, so particularly we are preferring Virechan karma. It fact not only on a condition of DSH, but on infertility or a HPO axis also. It is having a tremendous effect. So basically, Virechan acts like a biological detoxification, and which target the GI tract. Basically, what is the mode of action of Virechan karma? So it is a hepatobiliary clearance, in intestinal clearance is also there, so which escalate transit and reduces estrogen reabsorption, which lowers the thyroid binding globulin and increases the T4 free T4 availability. Systemic inflammation also reduce. So particularly T4 to T3 conversation, uh, which was suppressed by inflammatory mediators. Basically, it opens up by systemic inflammation reduction. Where we are particularly giving Virechan karma in hypothyroid patients, where a patient is having a hypothyroidism, or whether she is having a baseline hypothyroidism or a subfertility, and uh, uh, arm condition is there, or a sluggish liver metabolism, or for edema also, we are recommending Virechan karma with normal Virechan dravyas, classical Virechan dravyas. Again, for बस्ती अर्ध चिकित्सा कही गई है, बात रेगुलेशन करती है, न्यूरो एंडोक्राइन बैलेंस करती है, but how it is having an effect on particularly on thyroid disorder or infertility. So hypothalamus pituitary thyroid axis जो है, उसका जो हम मैकेनिज्म देखें तो colonic absorption of the herb, which are used in particular tail or basti tail, impacts on the vagal pathways and stabilizes hypothalamic TRH regulation, which reduces sympathetic overactivity and improves TSH rhythm. So basically, it balances what, which controls all endocrine nervous coordination. Why we are recommending Basti? Hypothyroidism patients are show a vitiation of what, means a fatigue or a dryness of hair or a skin or a neuromuscular worry. So Basti enhances short chain fatty acid, which improve thyroid hormone receptor sensitivity, improves microbiome health, and which is essential for T4 to T3 conversation in the gut, and reduces colonic inflammation, and autoimmune hypothyroid patients also benefited by this. So thyroid function basically closely depend on gut health. And Basti, nowadays it is proven that Basti is the strongest gut endocrine modulator in Ayurveda can offer. So it improves systemic hormone, improve peripheral T4, T3 activation, reduces chronic inflammation, and basically it's a hormone activation support we are giving. Generally, classical Virechan medicines which we are using is Trivrit, Aragvat, or Trifala. Trivrit में Trivrit अवले generally we prescribing. In Basti, Dashmul Niro Basti or Akshirbala Anuvasan Basti, Sahacharadi, Punarnavadi Niro Basti, Manjistadi Niro Basti, or Balashvaganta Anuvasan Basti. Okay, now fertility according to Ayurvedic view, again, Gandhyatva is also not described as a separate disease in Ayurveda. So, if we show in allopathic science, they presented infertility from a diagnosis to IVF or ART extent. So here also they de- def- primary definition of a Vandyatva is defect in any of a Garbha Sambhav Samagri, whether it is a Rutu, Kshetra, Ambu, or Bij. Strotodusti is there, Agnimandhya is there, especially Artava Strotodusti and Rasava Strotodusti. Maybe Stanyava Strotodusti is also considered due to higher prolactin level. Again, decreases the chances of ovulation. Several yoni vyapad also present with the symptoms that resemble to Vandyatva. Most important point here is that the definition of a Vandyatva is based on Garbh Sambhav Samagri. So, disturbance in or a defect on all of four things basically result on Vandyatva. In Nidan, Vata Visheshan basically is there, Artava Dusti, Beach, Yoni Vyapad. So, if we see the scenario, basically due to, I mean, in eye view of hypo or hyperthyroidism, they are not only developed due to Nidan but also aggravated them further. So they basically create a vicious cycle. So stress or poor nutrition, irregular diet, or agnimandhya, atitikshna agni, or any kind of a metabolic imbalance disrupt thyroid physiology, and in return there is a alteration of dosha dhatu, strotodusti is there, and this process further worsen when the thyroid hormone imbalance, so it all this condition directly disrupt HPO axis, which altering GnRH level, LH level, FSH secretion, which leads to anovulation, irregular ovulation, irregular cycles, luteal phase defect, and all this ultimately thyroid dysfunction and all this nidan mutually are perpulate one another, and they compromising the Garbhasambhav Samagri and increasing the chances of Vandyatva or subfertility. So if we see the why infertility basically develops in special context of Garbhasambhav Samagri. Disturbed Rutu means irregular ovulation. This link directly shows what we discussed in previous slides. Hypothyroidism or hyperthyroidism both contribute to ovulatory dysfunction. Kshetra disorder, mainly it indicates endometrial insufficiency. Nowadays, thin endometrium is also a very considerable thing according to allopathic science also. So hypothyroidism can reduce endometrial vascularity and decreases the endometrial thickness. Which makes uterine environment inadequate for implantation. And if we saw quality of ovum is also decreased when there is a hypothyroidism, so which shows a bija dushti. Poor ambu deficiency, which is a poor nourishment, whether it is bodily poor nourishment or overall or endometrial vascularity, we can also consider that as a poor nourishment. Okay, now as we previously discussed, though, in hypothyroidism, rasakshaya and medvruti, so there is a poor arthav production here. For arthav, we are considering a word ovum particularly. Actually, arthav also suggestive of oligomenorrhea or hypomenorrhea. In hyperthyroidism, dhatukshaya happen rasa and majja dhatukshay, which is primarily effect on endometrial development, poor endometrium and mm, implantation issues are there. So hypothyroidism pathway is like due to Agnimandhya. Rasa formation or a rasa dhatu is vitiated, or a poor quality of rasa dhatu is directly affects on nourishment of hypothalamus pituitary ovarian axis. And so body tries to compensate for a low thyroid hormone by increasing TRH from hypothalamus. So elevated TRH increases prolactin levels. Again, high prolactin suppresses GnRH, and primary signal it is for HPO axis. When GnRH pulsatility is reduced or irregular, so pituitary secretes FSH and LH in insufficient or incoordinated pattern, and which uh, which is directly effect on ovulation. When FSH level is inadequate, so follicle cannot grow properly. So maybe arthokshaya condition we can correlate that. So anovulation is the maybe due to immature follicle. Ovulation is not completely absent or delayed, or maybe irregular. Progesterone levels are low, which is also effect on endometrial thickness or vascularity, which suggests kshetra insufficiency. Mature ovum are not there. So again, there is a less chances of a pregnancy, so which is result in vantyatva. So if we consider hyperthyroidism, so basically excessive level of T3 and T4 causes rasa and majja dhatu kshay. So if we saw what happened to HPO axis level, so basically high thyroid hormones increases the sensitivity and speed of a thalamic activity, which again causes irregular secretion of GnRH. There is erratic LH and FSH secretion. They released irregularly, and which leads to failure to of ovarian follicles. They mature too quickly, or inconsistency in their maturity, or and short cycles are there, and ovulatory cycle are there. Basically आतवह स्रोतस दुष्टि progesterone supports the becomes suboptimal. So luteal phase defect is there, endometrial thickness is there, and due to implantation failure vandhyatva is there. So hypothyroidism create anovulation basically, and implantation failure occurred by hyperthyroidism. Basically, which these are the lakshana which is related to infertility. These are the fertility specific lakshana. In general thyroid system, we are symptoms we are not considering. And for hyperthyroidism, there are short cycle, and excessive bleeding is there. So again, for these, although our main subject is not exclusively infertility, it's a thyroid hormone dysfunction is one part of infertility. So I am just outlining commonly used yoga of infertility. So Kesha Google also we can use in infertility, and Kashnar Google also we can use for TSH and 3 level. It normalizes the level, and also increases the chances of normal ovulation. So how basically how these yogas help in hypothyroidism? So action of this Ayurvedic formulation, uh, generally we can understood their effect on a metabolism, or a neuroendocrine regulation, or a tissue level nourishment. So basically they improve metabolic agni, enhance peripheral conversion of T4 to T3. They improving the hepatic cellular oxidative metabolism. Rasayan drugs are there, like Shatavari and green preparation also. They reduce this stress-induced hyperprolactinemia, which is the major cause of suppressed GnRH release and anovulation, in particularly in hypothyroid patient. So by reducing cortisol and improving metabolic rate, this formulation help the normalize the HPO axis and correct the delayed ovulation, improve endometrial thickness, endometrium vascularity, and follicular development also. So hyperthyroidism also, they also protect uh, rapid धातुक्षयात्मक अवस्था, and the shmul particularly help to regulate neuroendocrine overstimulation, and it also stabilizes GnRH pulsatility. modulate inflammatory pathways and glandular abnormalities जो है उसको भी वो ठीक करता है. So थायराइड हॉर्मोन्स पर्टिकुलरली क्या इफेक्ट करता है, तो ओव्यूलेशन, एंडोमेट्रियम और ओवेरियन हॉर्मोन्स पे, बोथ हाइपो और हाइपर. So both are affect the conception or female fertility. So takeaway of this session is you should correct Agni, remove arm, restore Vat cup balance, and rebuild Artha. So basically, when thyroid imbalance, there is a fertility imbalance. We can offer preventive and corrective pathway both. So we have to particularly combine diagnostics with classical therapy. So here I am. Thank you. Here I am.
Thank you very much, madam. Thank you very much. Really mesmerizing, very easy, in easy word. Excellent. You are a great orator. Please do join every day. We are discussing every topic related to our health, religion, spirituality, everything. Excellent, madam.
Thank you very much, sir, for giving me chance to share my view in international platform. I am very grateful.
Thank you जी.
Okay, thank you, sir.
आप इसकी YouTube लिंक सब्सक्राइब शेयर कीजिएगा जहाँ जहाँ
Okay,
है उसको जिससे हम लोगों की ये परिश्रम लोगों के काम आए.
thank you. हाँ हाँ सर, thank you very much, sir.
थैंक यू जी. मैं अब डॉक्टर निशांत शुक्ला जी को सादर आमंत्रित करता हूँ उनके कमेंट्स के लिए.
इट वॉज रियली इंफॉर्मेटिव स्पीच. हर एक पक्ष को अच्छी तरह से जो है ये डिस्कस किया. थायराइड की अगर हम बात करें तो थायराइड ये सबसे पहला हार्मोन के बारे में हमें मालूम हुआ था और उसके बाद हम इतने सारे हार्मोन्स की इंफॉर्मेशन हम जो है वो प्राप्त कर पाए हैं. थायराइड कोई स्पेसिफिक एरिया पर इफेक्ट करता हो ऐसा नहीं है, पर बॉडी एज ए होल पर इसकी इफेक्ट होती है. और किसी भी हार्मोन के फंक्शन को हमें समझना हो तो जैसे कि रुजुता जी ने बताया कि अग्नि का एक इम्पोर्टेंट रोल है और अग्नि की मांद्यता से या अग्नि की अतिदीप्ति से धातु का क्षय या फिर धातु की वृद्धि होती है. वाग्भट में इसका जो है वो वर्णन मिलता है. तेषां साधाति दीप्तिभ्याम धातुर्वृद्धि क्षयोद्भवः. तो जब धातु की अतिवृद्धि होती है, जब धात्वाग्नि की अतिवृद्धि होती है, अतिदीप्ति होती है, तो धातु का क्षय होता है और धात्वाग्नि की अतिमंदता के कारण धातु की वृद्धि होती है, जो कि हमें ओबेसिटी वगैरह में मिलता है. और हाइपोथायरॉयडिज्म इंड्यूस ओबेसिटी जो है ये हम कॉमनली देखते हैं. तो एक ये है कि हमें थायराइड की डिस्फंक्शन की इफेक्ट हमें पूरे बॉडी पर मिलती है. सेकंड, थायराइड की डायरेक्ट इम्पैक्ट जो है ये फर्टिलिटी पर होती है और फर्टिलिटी के जितने भी पक्ष प्रचुता जी ने बताया ये काफी डिस्क्रिप्टिव, काफी विस्तार पूर्वक उन्होंने बताए हैं. और फॉलिकुलर फॉर्मेशन से लेकर के फॉलिकुलर सिक्रीशन, फॉलिकुलर सेपरेशन और उसके बाद की जितनी भी स्टेजेस है उसमें थायराइड फंक्शन का एक इम्पोर्टेंट रोल डायरेक्टली या इनडायरेक्टली है. कुछ एक जगह पर डायरेक्ट है, मोस्टली जो है वो इनडायरेक्ट है क्योंकि ये फीडबैक मैकेनिज्म्स पे काम करता है बेसिकली एफएसएच, एलएच और इनका रोल है. पर थायराइड का इनडायरेक्ट रोल इसमें जो है वो देखा जाता है. सिमिलरली एक कंडीशन कॉमनली देखने को मिलती है यूजुअली पीसीओडी या पीसीओएस में. ये हमेशा बनता है. पीसीओडी तो केवल जो है ये पॉलिसिस्टिक किडनी, पॉलिसिस्टिक ओवरीज में ये देखी जाती है. पर पॉलिसिस्टिक ओवेरियन सिंड्रोम जहाँ पर एक से ज्यादा मेडिकल कंडीशंस मिलती है, जहाँ पर इनफर्टिलिटी की जब हम इवेल्युएट करते हैं तो उसमें पॉलिसिस्टिक ओवरीज मिलेगी प्लस उसके साथ जो है वो हार्मोनल डिस्टर्बेंसेस मिलेंगी, ह्यूमरल फैक्टर्स मिलेंगे. तो ये पूरा जो है एक सिंड्रोम बन जाता है जो कि ट्रीटमेंट में काफी इम्पोर्टेंट इसको कंसिडर करना पड़ता है। इसकी भी इन्होंने चर्चा जो है वो अच्छी तरह से की है। इस मंच पर उन्होंने काफी अर्थपूर्ण चर्चा की, जो कि हमारे YouTube के सभी प्रेक्षकों के लिए सार्थक साबित होंगी, ये मेरा मानना है।
बहुत
और
बहुत
तो पवन
आभार
जी।
आपका निशान जी, बहुत बहुत आभार। मैं डॉक्टर सीपी शर्मा सर से उनके कमेंट्स की प्रार्थना करता हूँ। फिर हमारी नेक्स्ट वेबिनार शुरू होगी माइनॉरिटी राइट्स पर। आप लोगों से आग्रह है कि आप कृपया इसकी यूट्यूब लिंक्स भेजें, जिससे लोगों तक हमारा मैसेज पहुंचे। यही हमारी प्रार्थना है। न तो हम आज तक यूट्यूब से कुछ कमाए हैं और न कमाने की आशा रखते हैं, लेकिन ज्ञानवर्धन की आशा जरूर है। आदरणीय सीपी शर्मा जी हैं। प्रणाम सर।
नमस्कार नमस्कार। बहुत अच्छी प्रस्तुति दी बिटिया ने। बच्ची के जो थायराइड के पूरे आयामों को, सभी क्षेत्रों को टच किया। आदरणीय निशान जी ने वस्तु स्थिति से कि हमारे यहाँ जो अग्नि का कंसेप्ट है, हमारे यहाँ जो अंतःस्रावी ग्रंथिजन्य व्याधियां जिनको अष्ट अष्टौ निंदती ऐसा एक चैप्टर है हमारा, उस चैप्टर में दिया है। तो अंतःस्रावी ग्रंथिजन्य व्याधियों में जहाँ हमारी धात्वाग्नि और भूताग्नि, इन दो का विशेष रोल रहता है। तो धात्वाग्नि और भूताग्नि, अब भूताग्नि तो हमें जो अपन औषधि द्रव्य या आहार द्रव्य देते हैं, उस आहार द्रव्य ही उसका जनक होता है। उस आहार के जो भूत महाभूतों से जो उसकी वो बनी है, संगठन है, उसी किससे, उसी में उस महाभूत की अग्नि है। यह अग्नि हमारी वैसे 13 अग्नियां, जिनकी 4 अवस्थाएं आचार्यों ने उल्लेखित की हैं, उनमें चाहे हाइपोथायरॉयडिज्म